Good afternoon. It's my great pleasure to welcome you all to this e-seminar on inherited and acquired tubulopathies. My name is Ewout Hoorn. I'm from the Netherlands and I will be your moderator today. This e-seminar is organized by the Genes and Kidney Working Group of the ERA, and all of the speakers are also board members of this working group. It's my pleasure to introduce to you today's speakers and panelists who you see here. The first presentation and speaker will be Lucile Figueres from France, followed by Maria Vanessa Perez Gomez, who will be the panelist to the first presentation. And then the second speaker will be John Sayer from United Kingdom, with Ben Walsh as panelist. Before we get started, I have a few practical announcements. And there's an interesting feature which is real-time translation, which ERA has launched using artificial intelligence, where this e-seminar is translated into 7 languages: French, German, Italian, Portuguese, Russian, Spanish, and Turkish. And you can enable the audio by clicking on the globe icon at the bottom near the pulse function and choose your language. And for the captions, an external link to access through the browser will be provided within the chat. And another practical announcement is that by participating live, you will earn 1 European credit for continuous medical education. And this is an exclusive benefit for active ERA members. But in order to get the diploma, attendees must fill in the questionnaire feedback at the end of the e-seminar. So with that, I wish you a nice e-seminar. Please be interactive. You can use the chat. We will keep track of it and use this during the panelist sessions and also during the Q&A at the end of this e-seminar. And with that, I would like to give the floor to the first speaker. As announced, this is Lucile Figueres. She's an associate professor from France, and she will cover the proximal tubule, thick ascending limb, and also part of the collecting duct, and describe the tubulopathies originating from these tubular segments. Lucile.
Thank you very much, Ewout, and I really thank ERA for giving me the opportunity to talk today about inherited and acquired tubulopathies, and I welcome everyone to this seminar. I don't have anything to disclose. And the aim of this webinar is not to review every tubulopathies, but because as you may see here in this short list, there are a lot of them and a lot of different parts of the tubules, but we will focus on some diseases. So if I should introduce the tubule and the magic of the tubule, I will sort these different segments in 4 houses based on my personal and complete questionable interpretation. Proximal will be the good worker, Henle loop will be the smart one, distal convoluted tubules will be the cheat, and collecting duct should be the brave. Proximal tubule is for me the good worker because it's the segment that will reabsorb 2/3 of a lot of ions and solutes, but it will be the master of reabsorption of phosphate, glucose, and bicarbonate. It will reabsorb almost 100%, and also it will reabsorb the proteins. The Henle loop for me is the smart one because it will keep calcium and magnesium, which will be reabsorbed paracellularly, thanks to the creation of a transepithelial gradient, thanks to the transcellular transport. So it's also sodium keeper. And if you give loop diuretics, or if you have Bartter syndrome, for example, and this transporter does not work, you will have a loss of calcium and a magnesium. Distal convoluted tubule for me don't do much in quantity, but it's really different of the quality. But the regulation is really tight, and it's a really important tubule, and it remains mysterious in my opinion. And to finish, collecting duct has several functions. It will reabsorb the water, regulate the pH, keep the sodium, protect for hyperkalemia. So at the end, if collecting duct is not here, everybody dies at the end. So it's very important tubule too. After this quick overview, we will focus a little bit more in my presentation on proximal tubule and in the thick ascending limb. So proximal tubule will reabsorb a lot of ions and especially phosphate thanks to 2 transporters, NPT2A and NPT2C, that can be inactivated in a disease called HHRH. And when you have renal hypophosphatemia, it's mostly due to proximal tubulopathy. If you have renal hypophosphatemia, you will first check if it is not hyperparathormone hyperparathyroidism, because PTH will decrease phosphatemia, increasing phosphaturia, such as FGF23. Also, if you have renal hypophosphatemia, you have to check if proximal cells are damaged. It's the Fanconi syndrome. And also you should check for calciuria, because you have some renal proximal tubulopathies with hypercalciuria and hypercalcitriolemia, such as in Dent disease and Lowe syndrome. But first, to be sure it's a renal hypophosphatemia, be sure that the phosphate has been measured while the patient is fasting. And also, you have to measure TMPI on GFR with a blood and a spot urine sample collected at the same time. 24 hours phosphaturia is not really useful. And you must measure this TMPI on GFR even by using this Bijouette nomogram that you may already know. But in 2024, hopefully, we have free online calculators, as you can see here, but you have several online. And just you have to remember that TMPI on GFR is always low in CKD, because GFR is reduced. It is hard to describe all of inherited cause of Fanconi syndrome or acquired cause of Fanconi syndrome, as you can see on this long list here. But remember maybe that acquired cause of Fanconi syndrome are mostly obvious. You have, for example, myeloma, monoclonal gammopathy, or drugs that will induce Fanconi syndrome. And there is a new useful acquired proximal tubulopathy that is the use of glyphosine, because it will inhibit SGLT2. It's a SGLT2 inhibitor that will inhibit glucose and sodium reabsorption in the proximal tubule and induce in glycosuria. You can ask if it can be maybe useful in patients with tubulopathies, and I'm sorry, I don't have the answer. We have some data that magnesemia could be increased maybe in patients with diabetes treated by SGLT2 inhibitor, but the increase is really, really small. And also there are some theoretical data that phosphate absorption may be increased in a patient treated by glyphosine, but so far there is no report. And in my opinion, after one case with a patient with renal hypophosphatemia and use of SGLT2 inhibitor, you have to be cautious, and please report and share your data if you have a patient treated with these drugs, because we need to have more information. Let's move to the thick ascending limb of the Henle's loop. In this tubule, you have tight junction proteins called the claudins. They are very small proteins that will adjust the paracellular permeabilities of cations and anions in every segment of the tubules. And we already know some disease that will affect the claudins. And the most known is FHHNC syndrome from familial hypomagnesemia with hypercalciuria and nephrocalcinosis syndrome. These patients have renal hypomagnesemia since their infancy, and they also have nephrocalcinosis and nephrolithiasis. And also they have a chronic kidney disease at a very young age. Claudin 16 and Claudin 19 inactivating mutation cause this disease, and 16 and 19 are also expressed in the teeth. So this patient may have amelogenesis. So don't forget, when you have patients with tubulopathies, to make them smile in consultation and to have a look for their teeth. And also Claudin 19 is expressed in the eye, so patients with Claudin 19 inactivating mutation may be blind. So it's really severe disease. Most recently, we discovered a patient with a phenotype of FHHNC syndrome, but he was around 70 years old, and he has normal renal function and magnesemia a few years ago. So it was like a FHHNC syndrome, but acquired. So we looked for autoantibodies directed against Claudin 16 or Claudin 19, and we demonstrated that this patient have antibodies that were directed against Claudin 16 in this patient. The presumably cause was kidney cancer, and the patient was treated by plasmapheresis, rituximab, and steroids, and the magnesemia and acute kidney injury was improved by the treatment. It was the first description of acquired tubulopathies directed against claudin, but some other acquired tubulopathies with antibodies against other tubular proteins have already been mentioned, and maybe there will be a new one. Another disease, inherited tubulopathies regarding thick ascending limb, is inactivating mutation of claudin 10. And claudin 10 is not only expressed in the kidney, it's also expressed in the skin, but not in the skin of patients with Helix syndrome. Helix syndrome is the acronym we give to this disease with our study with Pascal Houllier and collaborators. These patients have electrolyte imbalance, but they also are not able to have sweat and saliva because of the expression of claudin 10 in the glands and in the skin. So how why do they have this phenotype? We see here the thick ascending limb, the glands in a normal patient, and ici in patient with Helix syndrome. We already demonstrated I already showed, the clever way of a thick ascending limb to reabsorb cations, and also it reabsorbs sodium paracellularly. And in glands, you will have saliva or sweat with the secretion of sodium at the apical side of the cells and chloride. In Helix syndrome, claudin 10 is not working, so the door for the sodium is closed. So they cannot reabsorb sodium, so they have a renal loss of sodium, such as Bartter syndrome. And calciuria and magnesuria will be decreased because calcium and magnesium will enter more. The door of the calcium and magnesium will be more open. And in the glands, they couldn't secrete sodium, so they won't be able to have sweat and saliva. We were several teams to describe this disease, so it's very nice to have already some several cases from several teams. And the phenotype, if you have to remember, it's like a Bartter syndrome without hypercalciuria, nephrocalcinosis, or nephrolithiasis, or it's like a Gitelman with hypermagnesemia. So to finish, we will move to the collecting duct, where acid-base regulation is one of the major tasks of the tubule. Patients with inactivating mutation of H+ ATPase or AE1, for example, have distal renal tubular acidosis. It is not always easy to diagnose renal tubular acidosis, and I will strongly recommend this guidelines from Detlef Buchenauer and collaborators, published in NDT in 2021. In front of metabolic acidosis, you have to check if blood anion gap is normal and there is no intestinal losses. And if you have all these conditions, you will measure the urine anion gap, and you will see if it's positive or negative. Honestly, we don't use this a lot, but it could help, and genetic also could help in this patient. If urinary anion gap is negative, it points to the fact that ammonium is adapted in urine, so there is a proximal defect because your collecting duct is able to do ammonia and to secrete H+. If urinary urine anion gap is positive, it may be distal renal tubular acidosis, but also it could be proximal with impaired secretion of ammoniac. So it's not so easy, and we all know that it's not so easy to diagnose renal tubular acidosis, and it could be also more easy if we can measure directly ammonium. But we can, but it's something very time-consuming, very easy, but very time-consuming. So it's not done in a lot of centers. And I will suggest to have a look in this interesting revision of NEF Madness 2024, actually running online, with these things we do for no reason, like measuring the urine anion gap, while we could do urinary ammonium, because recent study points that effectively it's better to measure directly what we want to measure. Acquired renal tubular acidosis, it's something we see oftenly in patients with kidney transplantation from 12 to 58% depending on the cohorts. It could be different kind of renal tubular acidosis. The type 1 is more frequent, but honestly, the type 4 could be very challenging in front of chronic hyperkalemia in our patient. The risk factor are the fact that GFR is impaired and also that the patient have high tacrolimus or CNI levels because it's directly sometimes an effect of CNI. So to conclude, and I think I'm perfectly in time, I hope so, in front of different tubulopathies, try to assess the segment that is impaired, because at the end we would just collect a urinary sample. So you have to phenotype correctly to know which is the tubule impaired. If you do the phenotype, don't forget to check the eye, the ear, the bone. Is there osteoporosis, for example, and teeth that may indicate that there is a chronic hypercalciuria. And in my opinion, acquired causes are sometimes easy because they are obvious. You have a myeloma or you have a drug or something, but genetic, it's more challenging, and you should do a genetic test. And to finish, I will suggest these two papers for good reading about inherited tubulopathies, and I thank you for your attention.
Thank you very much, Lucile, for this first presentation. And I would like to give the floor to Vanessa. She's a nephrologist from Spain as our first panelist.
Thank you, Ewout, for this presentation. And firstly, I would like to thank you for this excellent presentation, Lucile. I think summarizing tubulopathies is challenging because, as you say, that there are a lot of clinical presentations. And I think it's important to say that we usually equate renal function to glomerular filtration rate, but also tubular function is important, as we see, both because the homeostasis can maintain, and also because the tubule produce some factors as Plotov or calcitriol, for example. So it's important to understand the tubular function. When we have a patient who comes to our clinic with some phenotypes, we have to think in tubulopathies. Otherwise, we will never diagnose this disease. No, if we have a patient, for example, with growth alteration, defective ossification, dehydration, vomiting, electrolyte alteration, or nephrocalcinosis. So we should think to consider this possibility of tubulopathy. Of course, although phenotype can guide the diagnosis, it's recommended to perform a genetic test to confirm the tubulopathy, but it will depend on the availability of the in our country. No, we can perform a whole genome exome sequencing, or we can perform a panel. It depends of our availability in our clinic. So I think this is important, and to also to understand the treatment. There are no specific treatment for the most of the tubulopathy, but it's important to understand because in the future maybe we will have more treatments, or we will have even the gene editing for this patient. No? So it's important to understand and to find the reason of the tubulopathy in our patients.
Thank you very much. Thank you very much, Maria, for this, these comments. Ben, who's one of the other panelists, raised his hand for an additional comment, I think, or question, perhaps.
Okay, yeah, fantastic. So I just wanted to really say, how so I lower my hand. I've loaded now. Just wanted to say, yeah, so I thought Lucile had an impossible task there to try and fit in the entire nephron apart from the DCT. in 15 minutes. So, I mean, I think that kind of perhaps we should have been a bit more ambitious and perhaps thought about a session for DRTA and a session for NDI and a session for salt-losing tubulopathies. So, like I said, I think that's the presentation was fascinating, and I've seen Pascal present the acquired FHHNC and Helix before, and it's just completely fascinating. The acquired FHHNC, it brought the house down when we did the phys course. So, I just want to say that basically.
Thank you, Ben. I also had one question, Lucile, if I may. From my own practical experience, I sometimes get referrals for isolated renal hypophosphatemia, which turns out to be a rather frustrating diagnostic journey, often without a lot of result. Can you comment on this? What is your approach to these patients?
Yeah, definitely. We have a lot of isolated hypophosphatemia with renal calculi, hypercalciuria, hypercalcitriolemia, and negative genetic. I think it likes 2/3 of patients with no diagnosis. I'm looking for also, we have to work on finding new genes about these patients, and it's sometimes we cannot assess the diagnosis genetic, but for the treatment, there are some new approach also for this patient. For example, the fluconazole to try to treat this patient specifically with renal hypophosphatemia and hypercalcitriolemia. And I think in isolated hypophosphatemia, it's really important to know if they have hypercalciuria or not. So is there a Fanconi syndrome or not? And also to look at the bone, because also sometimes we have some rickets diagnosed in the adulthood. It's rare of rare, but they have like normal size. And when you do the genetic, it's like FEX mutation, and it's a rickets. So I think where you have to be complete and just really remember for everybody to do the phosphate only when patient is fasting and not eating, because it can decrease the phosphate on your blood sample. And also check PTH before measuring FGF23 or more complex things, because sometimes it's also just hyperparathyroidism, like for vitamin D deficiency.
Are you picking up any many raised FGF23s in these hypophosphatemias?
Sorry.
Are you picking up many raised FGF23s in these patients with isolated renal hypophosphatemia?
Really honestly, I don't do FGF23 really often because I can't do it in my center very often. I have to send it somewhere else, but I measure calcitriol really oftenly. And so when it's low, generally it's high FGF23. So for me, it's indirect markers of FGF23 secretion. And also, as you cannot, between TIO, for example, we don't talk about this, but tumor-induced osteomalacia with FGF23 secretion and genetic rickets, for example, you will have increase of FGF23 in both causes. So for me, you have to look for PTH, and if it's normal, calcitriol, is it low? And if it's low, it's maybe FGF23 secretion, because I cannot measure it oftenly. But I think it depends where you are, and you may have a different opinion.
Thank you, Lucile, for that addition. If there are no further comments, I also don't see questions yet. Oh, yeah, I do, actually. There's one question regarding distal RTA, whether you perform the urinary acidification test with furosemide and fluorocortisone. And I think the inventor of that test is actually attending today as panelist.
I think I will let Ben reply to this question. No, but I don't do it in my center now because ammonium is just starting to be measured in my center. So I think if you don't have the ammonium, the measure of ammonium, you cannot really interpret furosemide fluorocortisone test in patient because pH may be not enough. So far, I don't have experience.
Anything to add to that, Ben?
Okay, so you absolutely don't need the ammonium to interpret an FNF test. Essentially, people who've got inherited DRTA We showed they failed to acidify their urine either with ammonium chloride or with frusemide frigidcortisone, and they tend to have like barn door alkaline urine when you test them. So these patients would tend to have pHs about 6 and the DPH about 6. We use a cutoff pH 5.3, which is basically what Oliver Wrong used. I think the kind of experience has really shown in undifferentiated stone formers that's not a brilliant cutoff, basically. So if you're hunting for people with DRTA, it seems to me is usually pretty barn door. You've got a pretty high urinary pH, and I think the FNF test is kind of okay. The advantage of it is you can basically you can do it, and it doesn't make them nauseated. The disadvantage is it doesn't make you acidotic. So that basically.
Thank you, Ben. And I think with that, we'll be moving on to the second speaker. It's my pleasure to introduce Professor John Sayer as the second speaker, who will cover mostly Guiterman syndrome and other disorders originating from the distal convoluted tubule.
Okay, so thanks very much for the introduction. So yeah, I've been given the slightly easier task, I guess, to just focus in on one nephron segment. So I'm going to be talking about the DCT and Guiterman and some of the mimics of Guiterman syndrome. Here are my disclosures. So yeah, we're pressed for time in these presentations, and you could talk for an hour on any one of these different nephron segments, but in the time I have, I'll mainly be talking about Guiterman syndrome, but there is a mirror image of Guiterman syndrome called Gordon syndrome, which I'll touch on at the end. So I think it's clinically relevant and useful to be aware of what the difference is between Gordon and Guiterman. And as Lucile pointed out, we have a very sophisticated set of nephrons that allow for reabsorption. So we filter something like 180 liters of filtrate per day if you've got a normal GFR, and yet we pee out only 1 to 2 liters of urine. And so there's this incredible process of solute reabsorption and water reabsorption along the nephron. And as Lucile explained, the proximal tubule handles salt about 60%, the loop of Henle 25 to 30% of salt handling, and the DCT around 7 to 10% of salt handling. My favorite nephron segment is actually the collecting duct, which only handles 2 or 3% of sodium in all, but that's 2 or 3% of 180 liters of filtrate. And so the ability of the collecting duct to regulate both salt and water secretion is amazing. And remember, beyond the collecting duct, you're into renal pelvis, ureter, bladder, urethra, and that big outside wheel. There's no more salt handling beyond the collecting duct. Brown bears do have bladders that are able to reabsorb salt and water and give them a nice sleep during hibernation. Unfortunately, we don't have the same ability, and we have to get up at night to pee sometimes. So I'm going to be talking about the DCT, but remember, effects upon the DCT do have implications for the collecting duct. So the collecting duct, when it sees extra sodium, tries to rescue that situation and will reabsorb sodium. When the collecting duct doesn't see any sodium, it can't exchange sodium for potassium or protons. So that has effects as well. So no nephron segment can be seen in isolation, is what I'm trying to tell you. And we all use these beautiful New England Journal pictures of nephron segments. And here we can see that the main sodium co-transporter is called NCC, so sodium chloride co-transporter. That is the sodium transporter within the DCT. As Lucile mentioned, the DCT is very good at fine-tuning both calcium and magnesium, and I don't have time to talk about that today in great detail, at least. And so here is the calcium handling of the DCT, which is all very sophisticated. And some of the players here we're only beginning to understand, actually. Okay. And remember, you know, as well as the calcium sensing receptor, there is a magnesium sensing receptor. It's called EGFR. And we know this from mutations and drugs that affect EGFR, that this is now the kind of magnesium thermostat, which regulates magnesium transport in the DCT. So what I'm trying to say is the DCT does many jobs, and it's very good at fine regulating sodium, calcium, magnesium. Okay, so Gittelman syndrome is largely a monogenic disorder. So it's mutations in the gene and encoding this NCC, the sodium chloride co-transporter. So the effects downstream from that will be that you will lose sodium in the urine, and the collecting duct tries to rescue that situation. And there's two sort of resources I'd point you towards that I used to sort of create this talk today. One is a kind of case series and sort of review that we wrote together with a couple of my colleagues in Newcastle. And then the second one contrasts Gittelman's with Gordon syndrome and shows how the gene players are slightly different in Gordon syndrome. Okay, so back to Gittelman syndrome. So the defect is in this NCC. You might know NCC is the thiazide sensitive co-transporter, because that's exactly what it is. And so if you have Gittelman syndrome, it's like being born taking a thiazide diuretic. So you waste salt. And as we said, this nephron segment accounts for about 7 to 10% of sodium reabsorption. Therefore, compared to Bartter syndrome, the salt wasting is not as severe, but it can cause a clinically very significant phenotype. And so the phenotype depends on the collecting duct trying to rescue the situation. So we get salt wasting, and then we get secondary metabolic alkalosis and hypokalemia, because ENaC is working so hard to rescue that wasted sodium that it's exchanging sodium for protons and potassium ions, leading to this biochemical situation that we recognize of hypokalemic metabolic alkalosis. And the gene name that encodes NCC is SLC12A3, and it's autosomal recessive. The instance of Gittelman's is rare, but maybe it's undetected actually. So it's said to be about 1 in 40,000. But actually, we still identify patients late in adult life sometimes with Gittelman syndrome. And so I think that's an underestimation. Okay. The other phenotype that is peculiar to Gittelman syndrome is hypomagnesemia. And again, there's this relationship between salt reabsorption and magnesium reabsorption in this nephron segment. And so TRPM6, the magnesium channel, is downregulated if you have Gittelman syndrome, leading to this magnesium wasting and hypomagnesemia. There's various arguments about the hypocalciuria. So we know if we give someone a thiazide diuretic, you get hypocalciuria, and it's thought that actually in the proximal tubule there's upregulation of calcium reabsorption that accounts for that salt wasting. But that's probably not the whole story. But we do know that there is hypocalciuria, which differentiates Gittelman's from Bartter syndrome, where there's hypercalciuria. So compare and contrast furosemide and thiazides. Furosemide gives you hypercalciuria. Thiazides give you hypocalciuria. So this is Bartter's and Gittelman's in reality. Okay. How do these patients present? So, Bartter's would present as neonatal severe illness with salt wasting and pediatric ITU. The presentation of Gittelman's is milder. It's childhood or early adult presentations, although, of course, neonatal crises can occur. And the symptoms are quite severe, actually. So they're muscle weakness, cramps, tetany, sometimes paralysis, low blood pressure, fatigue, and these symptoms, can be non-specific, and people just generally feel very weak and unwell. And it's not until a set of UNEs is done in the casualty or A&E department that the defect might be noticed. But there are, if you have a patient in front of you that has a possible Gittelman syndrome, you can ask them about what they crave and what they like to eat. And these people crave salt. So they like salted peanuts and salty snacks and crisps and unhealthy stuff because they're driven by this desire to replace their sodium wasting. And, there may be childhood polyuria, polydipsia, and failure to thrive in these patients. The pregnant mothers of Guterman patients don't tend to get the polyhydramnios that's typical of Barter's syndrome, mainly because it's a less severe syndrome. But there is this overlap between this, the sodium chloride cotransporter and CLC-MKB, this basolateral chloride channel. And certainly I've got one family that were labeled as Barter's as early children and neonates. And then their phenotype became very much milder as they became adults. And they were shown to have mutations in CLC-MKB. And the reason for this really is the CLC-MKB is expressed both in the loop of Henle and the collecting duct, and hence gives this overlapping phenotype of Barter's and Guterman's. Okay, extrarenal manifestations now. So it's well known that Guterman syndrome have this thing called chondrocalcinosis, and it can occur in many different joints, but typically the knees, where they get this calcium deposition. And it's thought that hypomagnesemia drives this, although the exact mechanisms are not known. And then work largely from Fiona Corrett, actually in Cambridge, said that, you know, the hypotension also is not a lifelong thing. And these patients actually develop CKD and hypertension as they age. And that's thought to be due to this chronic salt wasting and chronic upregulation of their juxtaglomerular apparatus, leading to hyperenanemia. So the other thing is that patients with the hypokalemia can get cardiac arrhythmias and basically long QT. And so, you know, this is not a benign condition. You can get life-threatening arrhythmias in Guterman's patients. The biochemistry we've kind of touched on already, and I don't need to dwell on that, but, you know, an easy way to spot the difference between a Guterman's and a Barter's is to measure the urine calcium-creatinine ratio, because they will be hypocalciuric with Guterman's and hypercalciuric with Barter's. And like all these things, the spot urine is helpful, and a 24-hour urine is probably more accurate, but you have to bear that in mind with the inconvenience and whether the collection is accurate or not. Okay. Some mimics. So I've talked about the genetic form of Guterman syndrome, but biochemically, there's lots of mimics. So if you abuse laxatives, then you could have a similar phenotype with potassium wasting. But here the potassium wasting is in the gut, and so the urinary potassium would tend to be low, and the magnesium wasting by the kidney also low. Diuretic abuse, so thiazides completely mimic Guterman syndrome, but you know, you can't take a diuretic all the time every day. And so there are fluctuations depending on when the diuretic was taken in the urinary chloride secretion. And of course, you can test for diuretics in the serum or in the urine as well to see if they're abusing diuretics. And the exam question always involves a nurse who has access to these drugs, but actually anyone can get hold of diuretics if they look hard enough. Surreptitious vomiting is also one that comes in the exam questions, but again, this is volume depletion due to vomiting, and so the urinary chloride is low in this condition, and that's the main key. And then Conn's syndrome, primary hyperaldosteronism, will give you hypertension and low renin, whereas Guterman's is a hypereninic situation. PPIs and aminoglycosides can give you this magnesium kind of wasting phenotype. And of course, the drug history is very helpful there. And there's a syndrome that actually phenocopies Guterman syndrome called E syndrome. And I think I may have skipped over the slide, but the mutation here is in the basolateral potassium channel, KCNJ10, which is expressed in the brain. And so E syndrome comprises epilepsy as well as the biochemical phenotype of Guterman syndrome. Renal system diabetes syndrome can give the hypomagnesemia and salt wasting, and essentially, yeah, there is a role for this transcription factor to regulate some aspects of DCT transport. And then Barter's syndrome, we've already said they're very different, but the urinary calcium is the key to differentiate Guterman's and Barter's. And genetic testing should be straightforward. You're looking at two genes, essentially SLC12A9 and CLC-NKB, and that will secure a precise molecular genetic diagnosis. But you do get surprises when you test genes, in that I have patients with barn door biochemical phenotypes of Gitterman syndrome, but only one mutated allele. So maybe the second allele is deep intronic and we've missed it, or maybe sometimes one allele, a loss of function allele, is sufficient to give you a biochemical phenotype. So we're still actively researching these families. But by genetically testing them, you can get a handle on the severity of disease and, confirm the diagnosis and allow cascade screening of at-risk relatives. Here we are, the slide on East syndrome. So I mentioned this again, there's probably not time to talk about this, but because KCNJ10 is expressed in the brain as well as the kidney, you get these extra-renal manifestations. There are two groups that describe this gene. One called it East, the other called it C-same, but the phenotypes are the same essentially. Treatment. So I don't think we need to talk about this in great detail because in each country you'll have different access to different drugs, but essentially you replace the potassium, you replace the magnesium, but I also find that replacing the sodium, the primary defect, makes the patients feel a whole lot better. So I use slow sodium quite a lot in these patients, basically salt loading them, taking away their craving. And actually that does help the other electrolytes correct as well with these supplements. Okay, and then finally, I'm out of time, but Gordon syndrome, you'd expect, NCC is inactivating mutations leading to Gitterman's. Isn't there an activating mutation of NCC? So far, that's never been described, but Gordon syndrome is mutations in 4 players that regulate the expression of NCC and essentially upregulate NCC. So the complete mirror image. So these patients will have hypertension, hyperkalemia, metabolic acidosis, the complete mirror image of Gitterman syndrome. And these patients are picked up on routine biochemistry or might present in your hypertension clinic or with spuriously high potassium for whatever reason. And so look out for Gordon syndrome, and it's autosomal dominant in the large part, although there's one recessive form. So again, the familial pattern of hyperkalemia and hypertension might point you towards Gordon syndrome. So I think I'm out of time there. So my take-home message is the DCT is involved in lots of salt handling, fine regulation of calcium and magnesium, and the phenotypes that affect the DCT mimic thiazide diuretics with inactivation of that channel, and the Gordon syndrome is overexpression of that channel, giving you the mirror image phenotype. Okay, thanks for listening.
Thank you very much, John, for this interesting and clear presentation, which gives me the opportunity to give the floor to the second panelist, Ben Walsh.
Okay, right. Okay. Ewout, thank you very much, John. That was really great. Again, I think this kind of shows that like this 15-minute format is just too short, right? So like there's so much to sort of say about this stuff. And yeah, this is a traditionally very confusing kind of field that lots of people, I think, with some justification, find sort of kind of boring and a bit irrelevant. I don't, obviously, but I think a lot of people do. I think it kind of like perhaps the ERA could give us some more sessions. That'd be quite good. Anyway, so what I was going to say, John, you didn't mention anything about mitochondrial DNA mutations in Gitterman syndrome. So recently we had a new player possibly described by the Radboud group. So I wondered if you want to say anything about that.
Yeah, I mean, I think this is a rare condition, and I didn't have the time to talk about it. But yeah, we're still finding out actually more about these nephron segments, and that there is an antenatal form of Barter that's very interesting. Again, that we don't really understand, in that there are different molecular players antenatally compared to postnatally, and of course mitochondrial disease are heavily involved in proximal tubular phenotypes, but also distal tubular phenotypes as well. Yes.
Yeah, I mean, I've got no doubt that what they found, what I find most mysterious is the fact that you have this mitochondrial disease. In my experience, is something where you get sort of a very pleomorphic phenotype, which is scattered along with your diseased mitochondria throughout your various cell populations, and to have this affect just one tubular segment epithelial, it seemed quite remarkable, right? So it seemed to me that there's a bigger story there sort of going on. Okay, but then the second thing I want to say was like I guess a kind of comment about the kind of differential diagnosis with these electrolyte patterns of sort of hyperkalemia, metabolic alkalosis, and hypotension. So I thought you covered it like really well, but I guess the point I'll probably add is I think generally the Barter3s, the CLC, the CLIC-B mutations and Gittelman's can often be exact phenocopies of each other, including with a hypocalciuria with Barter3. And I guess that actually with the advent of cheaper, more universally available genetic screening, actually I very rarely have to make a biochemical diagnosis now. So like the antenatal Barters all come to me almost always pre-diagnosed, usually in infancy by the pediatricians. And the Barter3 and the Gittelmans, they're salt-losing tubulopathies, right? Which I just do the genetics and I get the genetics before. It gives me definitive diagnosis when actually you're sort of often kind of scratching your chin. The purging patients with eating disorders are a problem though. So I don't know about you, but I certainly get loads of those referred to me. And I think you very, very ably pointed out that actually, of course, there are volume deplete. They all have chloride retention, apart from the diuretic abusing patients. When they have the diuretic acting, they have a chlorhydrolysis, obviously. And that's kind of quite a useful thing. If they have a chlorhydrolysis, they should also have diuretic detectable in their urine. And, you know, it's worthwhile sort of pointing out that eating disorders, they're hugely common. And patients with purging, and often purge with more than one modality, I said often there'll be laxative and plus or minus diuretics, plus or minus vomiters, are actually more common in the general population than patients with tubulopathy. So we're all going to see quite a lot of those. And at the moment, I'm quite good at diagnosing them, but I'm not very good at doing anything else. So I just discharge them back to GP's care. And of course, these patients have quite a big all-cause mortality and mortality from suicide and so forth. But it's worse than depressives, actually. So that's what I wanted to say about that. And then just the other thing I wanted to say, and I think this common to all salt-losing tubulopathies, which includes Gittelman's, Barter's, E syndrome, and PHA1, which is the one which essentially mimics a potassium-sparing diuretic. All appear to have a salt-related immunodeficiency of Th17 cells. I wondered if you wanted to say, or you had any experience of that, or if you wanted to mention anything about that, basically.
Yeah, no, I don't know about that. So you'll have to fill me in. But there is a question on the chat actually regarding targets, because I think you can chase your tail with these patients and try and, you know, achieve normal chemistry at the detriment of their health, really. And so certainly if you overcook the magnesium supplementation, you'll induce diarrhea, which then gives you salt wasting and potassium wasting of another kind. So I think, you know, your targets have to be tailored to the patient, but they have to be realistic. And certainly I'm often happy with a potassium of 3 and a magnesium that, you know, that is above 0.55 or something in certain cases, because that's as, you know, otherwise they're ill for other reasons, despite your best.
Yeah, I think also kind of like us being happy is kind of often not really the point. So like you can cane someone thinking that they're actually taking these tablets, and often they're not taking them very much at all. Sander K and Slow K are both pretty disgusting. Slow K is quite a lot nicer. I absolutely agree with what you said about sodium chloride. So we try and get people up to about 10 tablets of slow sodium TDS in addition to a high salt diet. And the salt appetite is often very strong. I've got patients who used to have, if you ever looked after horses, now they've got a horse salt lick block. I've got a guy who used to have one of those in his pocket and sort of lick that. Or people used to put salt in their tea. People drinking pickle juice is very, very, very common. The primary problem is natriuresis and chlorhydrolysis, not kaliuresis. That's a secondary phenomenon from your aldosterone secretion. So if you can turn that off, then you should make everything better. So I think John, but after my clinic, we have lots of registrars in having lots of strife with loads of potassiums at 2.2 or 2.5. And I think it's kind of our job to kind of be chilled out about that.
Yeah.
And John, you did not touch yet on the possibility of giving patients with Gittelman syndrome amiloride or spironolactone. Are you advising against that? Because sometimes I feel it's primarily given to raise the plasma potassium rather than to cure symptoms.
Yeah, so I've got some patients that are on eplerenone or spironolactone, and it is quite good at propping up the potassium. I'm not sure how well they feel on these agents sometimes, but there are some patients that you just have to try everything on, actually, because they seem so unresponding to the electrolyte replacements. So yeah, amiloride and eplerenone in combination sometimes is what I've used. The magnesium, tends to be very difficult to correct unless you've got some correction of the potassium as well. So it kind of incentivizes you to try and get the potassium better. Yeah.
What magnesium do you use, John?
So for supplements, MagTab SR is my
that's what we use, yeah.
which is slow release, and it's magnesium lactate. I think it's quite well tolerated. I've got some patients that prefer the syrup in terms of magnesium glycerophosphate, and depending on which part of the country you're from, you get given other different types of magnesium as well. Patients buy stuff on the internet as well, on Amazon, these sort of electrolyte tablets and things like that. So you have to kind of check what else they're doing alongside what you're prescribing them, because there's all sorts of remedies out there.
I think that the lactate and aspartate are the ones with the best bioavailability. So broadly speaking, if you can get hold of those, they're usually a lot better and cause less diarrhea than the other ones.
Yeah.
I think we are slowly moving towards the Q&A session, or perhaps already started it. And there was another question in the chat about Guillemot syndrome. If you've ever seen it progressing to to kidney failure.
Is that for anyone? Sorry.
I guess we could start with John, but I'm happy to hear everyone's experience with this.
So I've not seen someone go to end stage, but CKD4 is certainly within my patient group, actually. So yeah, sometimes there is a lot of kidney damage. Maybe there's other reasons for this. Sometimes these children are given lots of drugs in childhood to help them grow. So non-steroidals and things like this that may then impact on their kidney function later in life. So I think, particularly I'm thinking of my family that looked like a Barter's but turned out to be CLC NKB and more Gittelman's phenotype. They were given all sorts of things during childhood to help them grow, and they led to progressive CKD.
There's actually a question on that just coming in about our recommendations on indomethacin or other NSAIDs in Guillemot syndrome. I think we generally discontinue these in adulthood, but I guess
them, yeah.
Yes.
Once the bones have stopped growing, yeah, I think my practice is to stop them. But yeah, I think I've seen patients with severe GI bleeds due to these agents as well. And, actually, if the Sandoz tablets kind of stick in the esophagus as well, they can be very, very erosive and cause lots of problems like that. So there's all sorts of, iatrogenic type effects in this patient group. And as you mentioned, their symptomology, if you add it all up, is generally pretty miserable. I've got patients that, are miserable the whole time because they feel so tired and lethargic and the muscles don't work.
Yes. If I take it back to that question about CKD earlier, we've got 70 Gittelman's patients, and I think the worst creatinine we've got is about 130. So I've not seen people with bad CKD with Gittelman's. Barter's, on the other hand, we've got a whole bunch of people who've gone to end stage, and that includes Bar 3. So there's something else that does not seem to be correlated with the severity of their biochemical phenotype or of their symptom phenotype, but we've had patients who've transitioned and gone into dialysis within less than a year. So as teenagers. So it's kind of I think these diseases have an unwarranted reputation for being kind of fairly benign, and actually a whole bunch of Barter's patients end up on dialysis.
Yeah.
There was another question in the chat, again coming back to the SGLT2 inhibitors that were mentioned in Lucile's talk, if we would recommend giving these to raise plasma magnesium in Guillemot or East syndrome, or perhaps other tubulopathies. And I think we can repeat Lucile's comment that we don't have the experience yet. There are a few case reports where, especially in patients with HNF1 beta nephropathies, seem to raise their plasma magnesium a bit more on SGLT2 inhibitors. So there might be an indication. I don't know what people.
There is. So I've used it in Fanconi syndrome because they all get CKD, and I mean I don't know if that's worked or not. We've also used it in Fanconi Bickel, and Franco has published on this recently. So as you know, Fanconi Bickel is a problem with glucose export from proximal tubular cells, and so you get a glycogen storage like phenotype with Fanconi syndrome and type 2 diabetes and diabetes mellitus and liver problems and if you can stop the efflux, the influx of glucose into those cells, then theoretically you should get cellular regeneration, and that should resolve the Fanconi syndrome. So we've got one patient who's on that at the moment. I've got to say the results have not been amazing, but we'll see what we can do. Franco's reported one patient who they seem to have a renal response to that.
Yeah, perhaps a final question. I see two questions related to this. You touched upon this briefly, John, is the occurrence of hypertension in patients with Guillemot syndrome. If we do see that, and if we would then also give RAS inhibitors to these patients.
Yeah, it's a difficult one. I don't know what the best agent would be for hypertension, but yeah, I guess if you think it's hyperenanemia driving it, then that would make sense.
Do you see much of this, John?
Sorry?
Do you see much of this?
No, only a handful of patients get hypertension in my experience.
Yeah, out of 70, I've got 2. So I think this is not such a big problem. There's that Lipton paper that showed that heterozygous carriage of SLC12A3 mutations was protective against hypertension. So I think it's all a bit on the air personally, but
yeah.
I do have a few patients with proteinuria. I don't know if that's your experience as well. I think it's more clear with Bartter syndrome, but I think it can also occur with Guillemot syndrome. Okay, I think we're getting to the end of this e-seminar. So with that, I would like to thank both speakers and both panelists and the audience for their participation and their questions. We haven't been able to answer all of the questions, but perhaps we will have some time to individually answer them in the chat. And I would like to remind you to participate in the survey. And I hope you enjoyed this e-seminar. Thank you for listening. Thank you for participating, and have a nice evening. Thank you.